PollenHealthcure, Beyond Care, It's Cure. It's my pleasure to introduce our esteemed moderator, Dr. Nitin Shinde, for today's webinar on battling Klebsiella infections, challenges, and solutions. Dr. Nitin Shinde, sir, is a well-known speaker and a major contributor for medical fraternity. Sir is associated as a senior consultant in infectious disease and internal medicines at Kingsway Hospital, Nagpur, with over 15 years of clinical experience. Sir has worked with leading institutions like Max Super Specialty and Bocard Hospitals. Dr. Nitin Sir holds an MD in internal medicine and a postdoctoral fellowship in infectious disease, along with international training from Harvard Medical School. We are truly honored to have him with us today. Now, I hand over the forum to Dr. Nitin Shinde, sir.
Yeah, thank you, Jayesh. I think I still remember the last meeting we had around a year ago. And there was a time when we started using Avibactam and Astronom in our patients, maybe around 1.5 years ago. And I think it was very difficult at that point of time to really talk about this molecule and its pharmacokinetics with a lot of other people. But I think we have now got significant experience for this therapy, and we've been seeing a lot of Klebsiella pneumonia. So today's topic of discussion is quite appropriate today, and we have fantastic presentations over here. So we have Dr. Pratik Patil. Dr. Pratik is an infectious disease specialist and is a great colleague, and he's associated with KIMS Hospital, Hyderabad, and I'm sure that he can throw a lot of light, and he must have seen a lot of good cases where he can share his experiences and his knowledge with all of us. And we also have Dr. Vishnu Raju with us, and he's a senior consultant and head of critical care at Department of Critical Care at Renova Century Hospital in Hyderabad. So I think we have two big giants who would share their experience, their cases, and we can really churn out a lot of things out of this discussion. And our panelist is Dr. Rahul Garg. He is MD PDCC, his diploma RCP path, is associate professor in microbiology at AIIMS, BB Nagar, Hyderabad. So we have fantastic people. So I think we would not waste a lot of time, and I request Dr. Pratik Patil to begin his presentation, and then probably we can discuss things ahead. So over to Dr. Pratik.
Yeah. Good evening, everyone. So as Dr. Nitin discussed about today's agenda for the meeting, so we are going to discuss about the Avibactam current role. I have kept it very brief discussion. I thought maybe we can discuss as we go along, and probably in the subsequent discussions and in question answers we can go through the details. So we have been using Avibactam for nearly 3-4 years at least now as part of ceftazidime Avibactam. Now we have other molecules. Now Avibactam is also available by Pollen as an individual molecule, and it is also part of the Astronom Avibactam recently. We need to learn more about this Avibactam, how we can make best use of this molecule and not to overuse it, and how to make rational use of it is what I would say, and then we'll discuss. So we all know that the burden and the resistance of the resistance with the this carbapenem-resistant Enterobacteriaceae or MBL producing organisms infections is quite high. These organisms are a critical priority pathogens as per by both CDC as well as WHO, and they have very limited treating options. We know that these are very common nowadays, and in ICU many of the patients have these infections, and all these patients compared to the other organisms definitely have higher mortality. If you consider the bacteremia spectrum with these carbapenem resistant Enterobacteriaceae, we see around 30 to 45% mortality, and in the same time if it is a VAP or HAP, the mortality can still up to be around 50%. So the resistance is mainly driven by enzymatic carbapenem hydrolysis. Sorry, am I audible?
Yes, yes, sir.
Yes, sir. Yes, sir. Yes, sir. Yes, sir.
Yes, sir, you are audible.
So as I was discussing, the main mechanism of resistance is enzymes for the carbapenem resistance here. And we know this Ambler classification, which is class A to D. Class A is basically KPC. Class B has most beta-lactam MBLs, which are NDM, VIM, IMP. And class D has OXA48-like enzymes. And the frequent co-production of beta-lactamases lead to the extreme drug resistance. So it need not be only one resistant gene. You can have multiple genes produced at the same time. So these Avibactam-based strategies are designed to address this resistance issue with good logic. Now, if you look into the Avibactam, what it does is it reversibly inhibits the class A, C, and D beta-lactamases. But it doesn't have any activity against lactamases, which is basically NDM, which is commonest in India. But we do see VIM and IMP also many times. So what it does is when you combine the Avibactam or beta-lactamase inhibitor with the beta-lactam, it enhances the PK/PD principle of the beta-lactam by increasing the time above the MIC, and it limits the resistance emergence. So like I said, it is inactive against the MBL group of beta-lactamases. That is where the role of aztreonam comes. Now, this is a very novel strategy which was adopted. So basically, aztreonam, we can't use aztreonam alone because the MBLs are often coexisting with the ESBL producing enzymes. So these ESBL enzymes inactivate the aztreonam. So when you want to use aztreonam or make the aztreonam work, you have to simultaneously inhibit the the ESBL. So here the Avibactam will inactivate the ESBLs as well as the other beta-lactamases of the Ambler class A, C, and D, while aztreonam will work against the NDM part of the beta-lactam, these carbapenem resistant genes. So that's why, as a combination of aztreonam and Avibactam, it provides the functional pan beta-lactamase coverage. Now, this is only by the enzymatic mechanisms. Other mechanisms can be still there. There is something called PBP3 insertions, especially seen in the E. coli. If that happens, again, this combination may not work. That's why we have to be understanding that this is based on the enzymatic demonstration. Phenotypic sensitivities may be sometimes different, and that is why we have to confirm this with the phenotypic sensitivity. Now, as per the surveillance data from 2017 to 22, aztreonam alone was only sensitive for 3 to 4% of the carbapenem resistant Enterobacteriaceae. However, when you combine the aztreonam with Avibactam, the susceptibility is increased to 98%. This is only for the carbapenem resistant Enterobacteriaceae. We are not talking about Pseudomonas, definitely not Acinetobacter. It is only Enterobacteriaceae. So it includes the Proteus as well, or Enterobacter cloacae. So there is a strong in vitro synergy of ceftazidime Avibactam with aztreonam, with 60 to 70% isolates can get resensitized, which were previously resistant. Now, the clinical outcomes and evidence-based positioning of these molecules. So now we have been having these molecules for last few years. So we have some reasonable data with that. So as per the observational studies, there is a clinical success of 75 to 80% with this combination. And the bloodstream infections mortality, which was, let's say, around 45 to 50, like we saw initially, it can be reduced to around 19%. So this is one trial, phase 3 assembled trial was there, which is looking at the MBL infections. There was a clinical cure rate of 42 to 50% versus the 0% in these patients. And also, the 28-day mortality was also very significantly reduced, 8% versus 33% in otherwise. So definitely it had a favorable safety profile. There was a minimal nephrotoxicity. And if you see where shall we place it in our clinical practice for therapeutic positioning, you can see that when there is a KPC or OXA alone, we can, as a mechanism of resistance, ceftazidime avibactam alone can be sufficient. Now, there is some data regarding the meropenem avibactam combination also, but as of now, probably it will be as good as it is not available, getting studied. But as of now, in such patients, only ceftazidime avibactam should be good enough. Now, when you have a confirmed or suspected MBL-CRE, which is a very common situation, very rarely we see in India the KPC being present. OXA is definitely more common, but again, OXA 48 alone is again not so common scenario. Maybe around 20% of the isolates will be having the OXA monoproduction. Otherwise, most of the times, either it is NDM or NDM with co-production of the OXA 48. So it will be nearly 70-80% of the time. The other two are there. And that's why we can't use it as an empirical choice alone. And we have to always use it as a combination initially, and then we can, once we have a confirmed sensitivity, then only we can change to the ceftazidime avibactam as a monotherapy. Now, when we have a confirmed or suspected MBL-CRE, aztreonam avibactam combination is the preferred one. Now, these are the few studies which I was quoting. So here, aztreonam avibactam for the treatment of serious infections caused by the metallo-beta-lactamase producing gram-negative pathogens. This was a phase 3 randomized control trial. It showed that aztreonam avibactam to be effective in treating patients with complicated intra-abdominal infections and or HAP or VAP, including severely ill patients and those with prior treatment failure. So definitely these were the seeker group of patients where it definitely showed effectiveness. And these numbers which we already spoke. Now, the aztreonam avibactam demonstrated potent activity against CRE collected from the US medical centers over 6 years period from 2017 to 22. Again, this one another article with activity of aztreonam and avibactam and recently approved beta-lactamase inhibitor combinations against Enterobacter and Pseudomonas from the ICU and non-ICU patients. Here, the aztreonam avibactam inhibited 100% of the Enterobacter from the ICU and more than 99.9% of Enterobacter from the non-ICU patients. So it is definitely very good sensitivity in the Enterobacter group. Now, antimicrobial susceptibility of Enterobacterials causing bloodstream infection in US medical centers. There was a comparison of aztreonam avibactam with beta-lactams active against the carbapenem resistance Enterobacter. So here, the aztreonam avibactam inhibited 98 to 100% of the CRE, including the MBL and OXA producers, and retained the activity against the isolates. Those were non-susceptible to newer beta-lactamase inhibitor combinations, outperforming the available comparators. So it was definitely better than the older BL-BLI combinations. Now, this is about the synergism of combination of ceftazidime with avibactam with aztreonam against MDR, Klebsiella pneumonia in ICU patients. Here, the addition of aztreonam to the ceftazidime avibactam is an effective therapeutic option against the MDR producing Klebsiella. So basically, it showed that the addition of aztreonam to the ceftazidime avibactam restored susceptibility in 62% of the isolates, which have marked MIC reduction. So it can be used for that combination. Now, this is what I was talking about initially, some studies which are showing the evaluation of meropenem alone versus combination with avibactam against carbapenem producing the Klebsiella. Here, this combination demonstrated a significantly enhanced effect in the experiments, not in the real patient case scenario, reducing the bacterial counts up to 4-fold compared with the initial inoculum. However, we have to consider here that the combination what we probably want has some inherent NDM activity also. However, meropenem does not have any independent activity against NDM like aztreonam. So whether this molecule will be the drug of choice subsequently, probably not. Still, we need the aztreonam in combination with avibactam. Maybe like ceftazidime avibactam, this can be used, may not be very, very superior. Now, in vitro and in vivo activity of the meropenem plus avibactam against MBL producing resistant club pneumonia. So, similar article what we discussed, this is just in vitro and in vivo activity of this combination. It improved the survival rates and median survival days were obviously prolonged compared to the drug resistance compared to the drug alone and the untreated controls. Yeah, with this, I'll stop and maybe hand over to the subsequent discussion. Thank you.
Thank you, Dr. Pratik. This is a very good beginning. So I now invite Dr. Raju for his cases.
Yeah, can someone share my slides, please?
Yes, sir.
Share?
Yes, sir. He is shared this also. Sir, over to you.
So my slides are not visible for me.
We can see.
You can see?
It's visible, sir.
Okay. I'll go. Sorry. 1 second. Yes, I can't see the slides. I'm trying to open in my laptop because I'm sorry. Okay. So today we'll discuss the cases, 2 interesting cases which we treated in our ICU. So using this Astronome and Avibactam. So as already Pratik was saying that, so multi-drug resistant gram-negative infections requires a very highly targeted approach. So this MDR and XDR Klebsiella pneumoniae presenting with the co-producing beta-lactamases. So it produces almost metallo-beta-lactamases and serine beta-lactamase activity. It is neutralized by these both antibiotics when it is given combined. So the standard carbapenems like meropenem. So when treating these cases frequently fail against complex enzymatic shields, so leading to a worsening sepsis and acute kidney injury critical ill patients. So using these both Astronome and Avibactam in combination addresses all these MBLs and serine beta-lactamases effectively and increasing the cure rate. So the synergy equation, it is a comprehensive beta-lactamate covers. This Avibactam acts as a shield and your Astronome acts as a sword. So Avibactam covers almost all the serine beta-lactamases like ESBLs, AMPC, KPC, and OXA48. And on the other side, Astronome, as already told, that it is stable against your MBLs like NDM, VIM, and IMP. So when you combine these 2 things, so it covers almost all the synergy also almost all the beta-lactamases, including MBLs and serine beta-lactamase producing co-producers. So the dual mechanism makes the combination a very highly effective salvage regimen in critical MDR XDR gram-negative infections where monotherapy fails. So we'll now discuss the case that was presented to our ICU. So here's a 70-year-old gentleman with multiple comorbids, diabetic, hypertension, and background CKD 3. So baseline creatinine was 1.8 with BPH. He was recurrently admitted to the hospital with UTIs. So recently he got admitted and he was treated for the UTI, which he grew Klebsiella pneumonia, which was ESBL. So it was meropenem central. He was cured of that and he was discharged. The same guy after 15 days presented to us with a fever, altered sensorium. So immediately we had, and his BP was low in the casualty. So we followed all the precautions. We sent all the necessary investigations and we did a CTKOB. CTKOB showing bilateral pyelonephritis with HUN, cystitis and prostatomegaly. So we already know that this patient has ESBL. So we started him on meropenem. as empirically. And because he has a bilateral pyelonephritis in H1, so we called for a urologist, and a decision was taken, and bilateral degestunting was done within 6 hours for this patient. In spite of degestunting and on meropenem, this patient started deteriorating. The shock worsened, and the encephalopathy worsened. We need to intubate the patient, and his AK was worsening. So within 48 hours, we got the cultures. The cultures showed it is carbapenem resistant. So here again, we thought, so here again we stopped the carbapenem, and we started here Avibactam and Aztreonam in a combination adjusted to the creatinine clearance. So you can see the TLC and the AKI. So where on day 1, when you are admitted, it was 22,300. Within day 3, it was up to 43,000. And his AKI was gradually worsening from 2.2 to 3.1. So after stopping meropenem and adding this synergy combination, we can see very drastic improvement of the patient. So like from 42,000, it came to 20,000. And his AKI also improved from 3 creatinine to 1.9. So patient condition stabilized, and he was discharged from the ICU and later advised for a bladder evaluation and TUR. So next we'll discuss about one more case, like ventilator associated pneumonia. This gentleman, 74 years, had multiple comorbids again, recurrent stroke, and he was recently admitted in other hospital with a hemorrhagic stroke. So where his GCS was low, he was intubated, and they did the CT. So the hematoma was huge. There was midline shift. The patient was took to emergency decompressive craniotomy there. So they started treating him there. So on day 2, day 3, I think he started worsening. There was infiltrates. His saturations worsened. His ventilator requirements are worsened. His AK has worsened. So because they don't have the nephrology facility there, they shifted this case to us. So when he came, POD 5. So when he was in shock, there were lung infiltrates in the casualty and worsening hypoxia and AK. Immediately we did a HRCT test, and we followed the ARDS protocol, and we had sent the ET cultures immediately. So here we escalated the antibiotics here to carbapenems, and the patient started deteriorating continuously in spite of adding the carbapenem. Then we suspected, and meanwhile our cultures came back which showed MDR Klebsiella. So then here we stopped the carbapenem, and we started injection Avibactam and Aztreonam in this case. So again you can see that. So after 48 hours, his TLC came down from 25,000 to 14, and his AK from 2.9, 3.1 to it has come down to almost 2.9. Okay, so at least after 72 hours, the PF ratios were improved, and AK has also started resolving, and we could successfully extubate this patient after 72 hours of targeted therapy. So here we need to understand, so evaluating the modern salvage therapy against the standard polymyxin therapy. So here the efficacy profile like Aztreonam and Avibactam synergy. So we had many other options to choose at that point of time. We thought, can we use polymyxin or colistin, but we chose broad spectrum coverage like MBL and the serine co-producers. And because with this there is least renal sparing, and activities allows AK resolution, and neurologically it's lower neurological neurotoxicity profile when compared to the other drugs. So golden rule, if it is an NDM MBL pathogen, think Aztreonam Avibactam before polymyxin. So preserving clinical efficacy through rigorous antimicrobial stewardships. So we need to acknowledge there is resistant to Aztreonam and Avibactam combination is biologically possible. Yeah. So avoid inappropriate and empirical usage. Reserve strictly for confirmed MDR, XDR, gram-negative infections. And rigorous diagnostic stewardship ensures this remains a viable life-saving salvage regimen for our most critical patients. So targeted precision ensures we do not lose our stronger defense against evolving MBL group. Thank you. So we'll open for discussions. Over to you, sir.
Yeah, I think these are two good cases, and the appropriate intervention of doing a targeted therapy. So I think I wanted to ask question to Pratik. Dr. Pratik, in your practice,
Yes.
how do you go ahead? I mean, do you use Avibactam-based therapies as an empirical therapy or a targeted therapy or both in certain circumstances? Or would like to know what are the circumstances where you are okay using it even in an empirical situation?
Okay. See, I do use, obviously, many of us are now using more and more of the Avibactam-based therapies. Now, if I'm really sure what is my likely source, let's say if it is a clear UTI with a background history of previous history of multiple urinary infections, including the carbapenem used in the past, and my patient is sick enough that to be in the ICU with multi-organ dysfunction shock, those cases probably I would use the astronom-based therapy upfront. Now, if let's say hospital-acquired infections, yes, again it is there, but in my center I still see significant numbers of the Acinetobacter and Pseudomonas sometimes. So that's where the problem is. So if you see, definitely this astronom-based therapy and Avibactam therapy doesn't cover the Acinetobacter at all. So if you have a problem of this Acinetobacter where your isolates are there, then I think it cannot be a part of your empirical therapy early part. Same thing, if your Pseudomonas is also there, then again it may not be a good choice to use an empirical choice. Now, what we can do in these cases is, if your syndrome is where it is likely to be, let us say, whenever there is a line-related infection, bloodstream infection, or if it is a hospital-acquired pneumonia, then Acinetobacter Pseudomonas are one of the big possibilities. So in those cases, I do not usually go for a astronom Avibactam-based therapies. However, if my diagnosis is a UTI or it is an intra-abdominal infection, let's say a biliary sepsis or something, in those cases, probably I use them upfront because the chances of Acineto and Pseudomonas coming there are relatively less.
Correct.
Unless there is any foreign body, any pigtail or anything which got secondarily infected. So in those cases, I use it as a primary therapy. Skin soft tissue, again, not much use. So I would say probably whenever it is a clear UTI and intra-abdominal infections, I use it as an empirical therapy. Or otherwise, if I have, let's say, I have started somebody's not so bad, I have been on carbapenems and I get a call from the lab saying there is a gram-negative growing. I do a biofire PCR or multiplex PCRs, or maybe sometimes if cost is an issue, we can do a carbar test, or we have the immunochromatographic test which can tell us the resistance pattern of the carbapenems. Based on that, and if your colony is also supporting enterobacteriaceae, the growth on the agar plate, in those cases we can still make a calculated guess and use these drugs instead of polymyxin. So that's how I approach these cases.
Yeah, I think that is right. Liver abscess is one such situation where you'll upfront think of empirically when you start thinking of putting patients on Avibactam and astronom. Dr. Vishnu Vardhan, I would, since I have seen in critical care, a lot of people have strong faith on polymyxin-based therapies. Polymyxin tigecycline combination, almost all of them, the patients are sick, and there's multi-organ dysfunction. Sometimes the source is not localized, and most of the times they have a feeling that polymyxin tigecycline will solve most of the problems, and they try to keep Avibactam astronom as a reserve drug. Any take on this? I mean, how would you try to play it?
So, as a reserve drug, no, when it is proven enterobacteriaceae, because we know your polymyxins won't work. So, because in our ICU antimicrobial, our Acinetobacter is very, very low here. Actually, it's only around 10 to 20% of all the cultures are enterobacteriaceae. So most of the are E. coli or Klebsiella pneumonia. Almost 70 to 80% of our infections are this one only. So polymyxin, when to use polymyxin, I should be very careful because it causes renal failure and it is not a good choice. Maybe I have to use colistin for urine. So the chances of renal failure and achieving that concentrations in the plasma is very difficult in when the patient is having renal failure. Okay, so in these cases, it is very difficult and worsening of renal failure. Patients going into dialysis will be so more with polymyxin-based therapies. So in these cases, I choose Avibactam astronome combinations. So that is my call on that.
Yeah, that's right. I mean, unless and until you're thinking about an Acinetobacter sepsis,
Acinetobacter, yeah.
There is no point thinking polymyxin tigecycline as a primary therapy.
Yeah.
And most of the good ICUs, they do not have Acinetobacter. Our problem is still Klebsiella and sometimes MDR pseudomonas or other Enterobacteriaceae. So my second question is to Dr. Rahul Garg. Is he here? Yes, yes. Dr. Rahul Garg, I just wanted to ask you that how frequently you see hypervirulent Kleb pneumoniae in your practice, and do you see any discordance between phenotypic and genotypic variants? And do you do gene sequencing of these type of cases? I mean, have you done it anytime in the practice? And can you just share your experience with us?
Okay. Thank you, sir, for pointing out this regarding this strain. So first, thanks to Pollen to bring out the Klebsiella into consideration. Now, the thing is, the Klebsiella, the epidemiology is totally changing. Initially, we learned that there is the strain which is the classical Klebsiella pneumoniae, which was there, and now because of the plasmids which are coming into picture, apart from the chromosomal resistance, the change in the picture is towards the hypervirulent Klebsiella and the convergent classical Klebsiella, which is happening. So if we talk about the Hyderabad locality, which we have studied, basically whatever the Klebsiella which are coming in from the severely infected patients, basically from the bloodstream infections and the ventilator-associated pneumonia, we are finding more of the cases of the convergence which is there in the classical Klebsiella pneumonia. Around 72.5% we are finding it to be the convergent Klebsiella pneumonia which is there. So what do you mean by the convergent Klebsiella pneumonia classical is that it is having both the MDR genes which are there, and in the plasmid there are the valence genes which are there. So this is the convergence which is happening. Regarding the hypervirulent Klebsiella per se, we have found only in 2 cases till now which are there. So it is very less, particularly in the Indian origin or the Hyderabad origin, which we are seeing for the hypervirulent Klebsiella, which is in comparison to the convergence which is happening. Now the second point is regarding the how these vary when we talk about the therapy per se. Okay, because for the clinicians that is the most important, whether it is a hypervirulent or the classical convergent, how the therapy differs. So as I told, the convergent classical, there is a lot of resistance which is coming in, and for that these kind of therapies which are being discussed today based on the Avibactam-based combination, that particularly are helpful. But in the case of the hypervirulent Klebsiella, now again there is a little bit of convergence which is happening in the hypervirulent Klebsiella in terms of the plasmid itself. So there are some resistance genes which are now occurring in hypervirulent Klebsiella, but that are more towards favoring towards the region of the China, which have reported more towards it. But in Indian origin, we till now from Hyderabad, I have not seen such kind of cases.
Okay, all right. I mean, in my practice, I occasionally see 3 or 4 cases in a year, and they're typically immunocompetent, having metastatic disease or probably liver abscess.
The definition of hypervirulent Klebsiella is very tricky, actually.
Yeah.
So, and to find out hypervirulent Klebsiella in comparison to the hypervicomucous Klebsiella, which is there, that is totally different. So when we talk about the hypervirulent Klebsiella, then there are the 5 genes which are involved in the Klebsiella pneumoniae. Basically, the most susceptible and the most sensitive one is the Avibactam gene, which is there. So that has to be taken into consideration for the either from the sequencing or through the multiplex PCR, as you have asked for. And apart from that, till now WHO has not been clear what should be the ideal definition to call it as a hypervirulent Klebsiella per se. So that is currently a little bit of debate which is going on. So,
correct. Pratik, do you have any experience of what difficulties you find treating this type of hypervirulent Klebsiella?
Yes, like you said, we do come across some cases of these hypervirulent Klebsiella. Sometimes, yes, maybe a few cases once in a couple of months, maybe I see these cases. And treatment, again, you see, it does work. The conventional therapies do work there. But again, the problem is maybe because it's hypervirulent, the patient comes in a bad sepsis cascade already set in. So to reverse the whole process, it may take time. So we see that the patient keeps on worsening despite being on some sensitive therapy. Patient still takes time to turn around to show the response in terms of the hemodynamic parameters, the organ dysfunctions. It probably would take time. So that is how it is. Maybe so, because again, not many times labs directly will call you and tell, okay, whether this is a hypervirulent strain. When you see the nature of the sepsis where the patient is looking extremely sick and despite appropriate therapy, relatively stable, good host, but still looking very sick, the overall organ dysfunctions are not, not great. That's very bad. Then we go and check with the lab whether do you think it is, they do a string test like Dr. Rahul mentioned. There are no definite criteria and not always you can do all the tests to say that this is a hypervirulent strain. It's only how it looks and how they do the string test, and if they feel that it looks like hyperviscous. That's the only way to prove it.
Yeah, correct. So I would also ask you a very tricky question. In your experience, what do you think, a fixed dose combination of Avibactam astronome is better, or giving drugs separately is better? What do you prefer?
See, now, like you have already mentioned, it's a tricky question. Yes. Okay. So now because to be frank, I had used this only in very few cases. And the reason had been mostly the financial cost. Okay. The reason, because the original innovator molecule is much costlier. And the other reason why I feel it is more convenient. The reason now that combination what I use is the reason of using it is the convenience. See, many times I have seen these things happening. Nurses, whichever hospital you take, there has been errors in administration. You have to administer both the drugs simultaneously as a prolonged infusion. And then sometimes they have some other things going on. Sometimes one goes first, one goes later. So there is a risk of potentially making this combination ineffective. If you start astronome first and then give ceftazidime, or let's say, Avibactam subsequently, it doesn't work that way. So you have to start Avibactam first and then give astronome at least, if not simultaneously, so that your Avibactam takes care of the ESBL first, and then the astronome directly is available for the killing the NDM. If you don't do that way, you are starting the astronome first, you are making that drug useless. So which are the difficult parts to explain to the nursing team? And that's why it is very, very important to make them understand that why it is important, or when you give simultaneously, why and how it needs to be given. So that is a major challenge in giving the two drugs as a simultaneous infusion. The other factors like having a separate infusion pump, IV access and all that is also there. But this is a major problem which I have because I'm going to use it in one of the very sickest patients. So in these cases, how the drug is given is very, very important. So if that is not being taken care probably, then it is a whole exercise is a futile. So that is the reason I think when we are giving as a two separate infusions, whether it was initially with ceftazidime, avibactam, and then astronome as a separate entity, or now with astronome and avibactam both simultaneously given, that is very important thing that we should all consider when we are giving simultaneously, because now there is a separate molecule which is coming as a single drug combination which can be easily taken, given, and we don't have to worry about all these issues. So that is the ease of convenience there, that it will be there. But this definitely we cannot mix it also. See, whenever I have used it as a two simultaneous infusions. I'm not sure how the others are practicing, but as far as I know, most of us who have who have used it are still using it as a separate infusions in two separate vials. Nobody is mixing it with astronome and then using it as a single infusion. So if you have any other experience on this, maybe you can share it. But that is my experience on this.
Yeah, that's true. And I only find that there is a lot of flexibility when you are using it separately, two different molecules. I do take a session of most of my nurses along with clinical pharmacists and try to explain them the concept of joint PTA in a simpler word, and they do get it most of the time. So senior nurses and clinical pharmacists and junior RMOs, they generally understand it is a very complicated topic or complicated, kind of subject. But generally my team take effort, fellows generally take efforts and try to understand, make them understand how this joint PTA works. So once you make them understand, it is easy. So I am using it, and it is very, very helpful when you have to really do a dose adjustment for patients, chronic kidney disease patients and patients on hemodialysis. It becomes easy than the fixed dose combination. That is my point. So Dr. Vishnu, so I'm
Right.
again asking you that what problems you have probably experienced using Avibactam and Avibactam-based therapies in your ICU?
So no, maybe Bactam. So recently, I didn't face any of this thing
People
except
should
for
be
this
aware of. I mean,
giving
it is,
simultaneously.
there is no doubt there is an excellent therapy. So what are the things you should take care of while you're using in your patients?
So it is already told. The only thing is recently I have seen few. I would like to ask the question because I didn't see any other major complication except for this giving if you give the simultaneously. I have used both this thing and separately as well. So almost I'm using for the last 1 year. So but I didn't find any major adverse or reactions or anything with this combination. So recently I have seen this Avibactam, the synergy resistant Klebsiella pneumonia are more common these days. I have seen almost 3 to 4 cases in the last 3 to 4 weeks. So are you also seeing these type of cases in your ICUs?
Yeah, they're everywhere. So the one of the common problem which we see with astronome hepatotoxicity, it is significant. And many times we would not realize that because patients have multi-organ dysfunction, their LFTs or OTPTs, they start rising slowly. And we may just attribute that to the underlying sepsis or underlying organ dysfunction. But astronome is a significant hepatotoxic drug. So we have to really keep a watch on the doses of astronome and liver function. That is the only problem, but which can be managed actually, which can be easily managed. So I think that is my concern with Avibactam-based therapies. And only thing is that you have to really look at PQPD, the way infusions are being given. So apart from that, it works well in as a targeted therapy. So Dr. Rahul, my question to you is: did you find any phenotypic or genotypic discrepancies or any discrepancies in synergy test? And what is your experience in Hyderabad? I mean, is there any difference in in vivo, in vitro? What is feedback from other clinicians to you?
Okay. So regarding the synergy between ceftazine avibactam and astronome, so there is before 2023 there was no such standard guideline which was there that how to do the synergy test. Various researchers were using either disk stacking test or E-strip cross test or elution test or broth microalgae dilution test for doing various and reporting the synergy which was there. In 2023, CLSI came with a standard method for using the disk elution test for doing the synergy which is there. Okay. So whenever we are seeing that there is a synergy which is not happening, so the first thing which you go to the clinician is what kind of method was used to do the synergy which was there, because based on those methods, the sensitivity and specificity varies a lot actually. If you just comparison between the disk stepping test and the disk elution test, there is a the susceptibility differs around 30 to 40% which is there, and because of which we see both a lot of false positive and false negatives which are there. So first thing which it comes to the mind is the what kind of test is there, and second thing, it differs between what kind of chemicals we have used for doing the synergy based on the manufacturers which are there. Okay. So most of the labs nowadays are using high media various discs or yeast strips or chemicals which are there, or we are using any other which are there. So that has to be taken into consideration along with the regular QCs which are put for the for a proper reporting of this synergy test which is there. Now coming to the scenario where we are looking into the synergy resistance, yes, we do find sometimes there is a synergy resistance, and that has a obvious cause which are being there. So the obvious cause is that we have to just keep in mind that our Indian isolates for Klebsiella pneumoniae has various mechanisms of resistance, which it is not only driven by metal beta lactamase. Mostly it is a dual enzyme or the triple enzymes which are being functioning into consideration. It is most of the time it is NDM plus OXA 48 like, or it is NDM plus 48 like plus MPCs or ESBLs, as Dr. Pratik also told in his presentation. So that has to be taken into consideration when we are finding a synergy that has that is resistant, which is there. So these are the three different points which have to be taken into consideration whenever we are seeing a synergy which is being not proven, or there is no ray of hope which is there, and simultaneously we have to think how to give the therapy otherwise.
Okay. Dr. Pratik, anything you want to add?
No, I think what Dr. Rahul mentioned is right. Synergy test, again, now it is getting more and more better standardized, probably because how you are doing the synergy test is also important whenever you are seeing a resistance. We do see sometimes, but not very common, not like 2, 3, 4 in last. Maybe 1 year I would have seen 2 or 3 cases with the synergism absent. But yes, how you do synergy test, always double check it with the test, because you are using the sandwich method or you are using the yeast strip or what. That also we need to check. Now that the Astronom Avibactam direct discs or direct strips are available, I think that should solve the problem probably, to see what is the better sensitivity method in this.
And what is your experience using Avibactam-based therapy in other pathogens like Pseudomonas or E. coli?
E. coli I have used. It works well. I have not had much of a resistance in E. coli also, though theoretically they say that you can have PvP3 inserts more often in E. coli than Klebsiella. But I haven't had anything there at such any E. coli observed with PvP3. Now, second thing, Pseudomonas, I have used more often the Astronom Avibactam combination with ceftazidime. So the original ceftazidime with Avibactam and Astronom, because overall the antibiogram, if I see for Pseudomonas in my institute, only 50 to 60% of the times it is sensitive. So since Pseudomonas it is there and you have ceftazidime, which is also an anti-pseudomonal drug, so I preferably keep it there in addition to the ceftazidime, in addition to the Avibactam Astronom. So whenever it is a Pseudomonas multi-drug resistant, I tend to use the old combination of ceftazidime Avibactam and Astronom rather than the Astronom Avibactam.
Correct. So this is important because ceftazidime has a very fantastic PvP3 binding mechanism. And when it is Pseudomonas, it is always better to use ceftazidime Avibactam-based therapy than using Avibactam alone. So I think that works a little better than any other thing. Astronom has if NDM, Pseudomonal NDM is little difficult for Astronom. And again, Pseudomonas have a lot of other resistance mechanism as well. So it is very tricky, and using it empirically is also very, very difficult. So I think we have been discussing this very good. I mean, all of us, all our speakers and panelists have contributed their experience in very well. Is there any question?
Yeah, Dr. Pratik Patil, I want to ask one question, as one of the doctors sent me the message. So the question is that in the mixed infections of Acinetobacter and Klebsiella pneumoniae, what could be the right choice of treatment to imply?
See, first of all, I say it is not common to see the mixed infections. If you are looking at a multiplex PCR in the lungs panel, which pneumonia panel, if you give that, then you have to see what is the likely. Both organisms causing simultaneous infection, less common. But if yes, if it is, let us assume hypothetically it is true infection, then I would probably use polymyxin tigecycline as a preferred drug, and maybe nepcolistin in addition to that. I have not seen any case with bloodstream infection with both these organisms. But if you are thinking of lung, probably I would use the polymyxin and tigecycline with nepcolistin. That is my opinion, but I think depends also if I have, let's say, Pseudomonas, let's say if you have identified Kleb in the blood. I'm just taking all the hypothetical concerns here. Now, let's say I have a Kleb in the blood, patient is sick, and acinato in the respiratory isolate, and probably lungs are not as bad. And then probably I will stick to the Astronom Avibactam, and then consider something. If I have some concerns about the lung, then I will have to decide whether I want to use, if it is VAP or not, whether I can use high dose TG, whether I should use polymyxin. But I think it is a lot of permutation combinations, and so many interpatient variations are there, which may have to consider and then take a call. Dr. Nitin, what do you feel about it?
Yeah, correct. I think BioFire is easy to order. It takes 2 minutes to order, but you should be ready to interpret it for 30 minutes. Yeah. Because sending BioFire just or any other molecular multiplex panel is not the way to actually interpret that data with concordance with all other tests. For example, if you're sending a lung BioFire, please make sure that you send a gram stain, you send a culture, and you try to find out what is colonizer and what is the real pathogen, which can be really, really tricky, and which actually end up giving more antibiotics to the patient. So, and we have to see which organism is dominant, which is causing more problem, and then choose the therapy. So all the multiplexes are tricky. They are very good tools for diagnosis, but you have to really interpret it very well.
Sir, is there any role of sulbactam with a high dose in these conditions?
Yeah, I think sulbactam has mostly efficacy, which has been there for the Acinetobacter alone. So for other organisms, I don't think anybody is, and there is any guideline to use sulbactam or any recommendations or anybody is using. It's only there for the Acinetobacter, that too only limited. See, with the presence of NDM so common in India, the utility of sulbactam itself is questionable in India, how much, and we can't really test also. So that is the main problem with sulbactam. But yes, as add-on therapy, I would maybe use in when very bad Acinetobacter infections, but I will not count on it. I will use it as a third drug, not a second drug also. So probably as a polymyxin, tigecycline or minocycline, whichever is the sensitive and use, depending on your antibiogram, and probably add on as a third drug in a very sick patient. Correct. Others, what do you think?
Yes.
It's the same thing.
So I would like to ask one question. Hello.
Yeah, please.
Yeah. As we all know that we have one combination of Astronom Avibactam, as you have said rightly, that is very costly to use that drug. So if we are using Astronom and Avibactam separately, then can you please guide us? What will be the dosing pattern of Avibactam?
Okay. So I preferably would be using the same. See, now the reason why the Avibactam Astronom combination is released and how it is basically they have increased the Avibactam dose per day. So previously, in the previous combination, we were using 1.5 grams of Avibactam in a day, which has been increased to 2 grams in a day in 4 divided doses. So I would stick to the same dose, which is 2 grams of Avibactam in 4 doses, so 500 mg QID, and Astronom, which was again 2 grams 3 times a day previously, it has been divided into 4 doses. So because that is the maximum safest dose of Astronom, which is 6 grams a day. And I would use that in the same way, 1.5 grams 4 times a day. So same dose, but separate infusions.
So sir, you mean to say that we are going to use 2 gram of Astronom with 500 milligram of Avibactam in Y channel, 6
No,
hourly?
no, no.
6 hourly.
It is 0.5 grams of Astronam and 0.5 grams or 500 milligrams of Avibactam to be given simultaneously, each over 3-hour infusion.
Okay.
After
So it
a
was
loading, which is 2 grams of Astronam and 0.67 grams of Avibactam.
so how to get that 0.67 gram of Avibactam? That's what my
That is a little
confusion.
challenge. That is a little challenge. It is not a little challenge. It is a lot of
Big
mathematical challenge for people to understand. Okay.
Because a lot of drugs will be wasted.
So you can
That's
round up
okay.
the dose. You can round up the dose. Avibactam you can round up. There is no problem.
Yeah, we can do that. See, it becomes a little easy for patients with higher, creatinine or increased creatinine, reduced creatinine clearance. But yes, Avibactam, you can just make it 2/3. Simple words: take 1 gram, dilute it, and take 2/3 of the volume for the
Okay.
loading dose.
Okay. Okay. Thank you. Thank you.
Any other question?
I guess there are no more questions. It was nice, oriented and detailed FAQ session. So I Ajinkya Virgambar, on behalf of entire Pollen Healthcare team, I sincerely thank our esteemed speaker, Dr. Vishnu Vardhan, Dr. Pratik Patil, moderator Dr. Nitin Shinde, and panelist Dr. Rahul Garg for sharing their valuable insights for battling Klebsiella infections. I also extend my gratitude towards all the participants who are involved actively and to the organizing team who have made this webinar success. Thank you all for your time and participation, and have a great evening ahead and happy weekend.
Yeah. Thank you. Thank you
Thank
all.
you.
Thank you so much.
Thank you so much, sir.